We now request all of you to please stand for the Ramaiah anthem.
We'll now have the invocation song followed by any lighting of the lamp. We request Dr. Radha, chairperson of the invocation.
We request the dignitaries to kindly come forward to light the lamp. जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। नाद ब्रह्ममयी जय वागेश्वरी शरणों ते गच्छामः। त्वमसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दितचरणा। त्वमसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दितचरणा। नवरसमधुरा कविता मुखरा स्मितरुचिरुचिराभरणा। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। आसीना भव मानस हमसे उन्दतु हीन शशि धवले। हर जडतो कुरु बोधि विकासं स्मित पंकज तनु विमले। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। ललित कलामयी ज्ञान विभामयी वीणा पुस्तक धारिणी। ललित कलामयी ज्ञान विभामयी वीणा पुस्तक धारिणी। मतिराताम्नो तव पद कमले मतिराताम्नो तव पद कमले। ऐकुण्ठाभिषवारिणि जय जय हे भगवती सुरभारती तव चरणों प्रणमामः। प्रणमामः प्रणमामः। Now we request all of you to kindly stand for the Ramaiah. Thank you, dear dignitaries, for a wonderful start to the program. And thank you, Dr. Rara, for the invitation song. We now request Dr. Sheikh Mohammad Aslam, Professor and HOD, Department of General Medicine, to kindly give the inauguration and welcome address.
So, good morning, everyone. Respected Chief Guest for today's CME, Dr. Shalini Muni Ma'am, Principal and Dean, Ramaiah Medical College, Dr. President, Ramaiah Memorial Hospital, Dr. Sumit Raisen, Professor and Head of Microbiology from AIMS Mangalgiri, Dr. Jayanti Savio Ma'am from St. John's Medical College, distinguished speakers, delegates, faculty members, and my dear friends. On the occasion of World Antimicrobial Awareness Week, that is November 18th to November 24th, and birth centenary of our beloved founder chairman, late Karma Yogi, Dr. M.S. Ramaiah, the Department of General Medicine, in collaboration with Hospital Infection Control Committee, welcomes you to this CME on Antimicrobial Awareness, current status, and action plan. Now, as you all know, antimicrobial resistance is an urgent global public health problem and a threat, and this is associated with approximately 5 million deaths annually. Antimicrobial resistance is increasing globally, and this is due to increased prescription as well as increased dispensing of antibiotics. And coming to India, antimicrobial resistance has become a great threat. Now, this is because of high burden of infectious diseases in India, higher antibiotic usage, self-medication, over-the-counter usage of drugs, and lack of awareness. So, one of the important tools for combating this is Antimicrobial Stewardship Program. So, to throw light on these burning issues, today we have eminent speakers from prestigious institutions who, with their vast experience in their field of expertise, will be throwing light on these issues. So we'll be having many enlightening lectures and discussions on various topics across the spectrum of infectious diseases, which include topics like interpreting cultures and antibiograms, treating multi-drug resistant infections, antimicrobial stewardship program, infections in critically ill patients, and many more. So once again, I wholeheartedly welcome one and all for this CME. Hope all of you will have an excellent experience and a rich academic feast. Thank you.
We now request our principal, Ma'am, to felicitate Dr. Aslam. Sessions now, I request the dignitaries to take a seat in the front. Now let's start with our first session for the day with this pharmacokinetics and pharmacodynamics of the antibiotics. The field of physician, our esteemed speaker, Dr. Hon'ble, who is the head of infectious disease and infection control in Aster DM Healthcare, who's live online in Kochi. Unfortunately, for circumstances, is joining us online from Kochi. Hearty welcome to you, sir, and we are delighted to have you with us. Also, now welcome the chairperson for the session, Dr. Vijay Ragaj, who is a senior professor in the Department of General Medicine, and Dr. Ananda Eshri, professor in the Department of Oncology. Dr. Vijay to kindly introduce Dr. Hon'ble.
Good morning. It gives me great pleasure to introduce the first speaker of the day. Dr. Hon'ble is a senior consultant and the head of infectious diseases and infection control at the DM Healthcare Kochi. He's a physician with over 15 years of experience and specialized training in the management of infectious diseases and infections in hospitals. His special interests are tropical infections, fever of unknown etiology, infections in the ICU, and HIV medicine, and also antibiotic stewardship and cost-effective evidence-based infection control. Anup is a fellow of the Royal College of Physicians and fellow of Infectious Diseases Society of America. Dr. Anup is an international ambassador and research grant winner of the Society of Healthcare Epidemiology of America. He is Healthcare Asia Management Award winner twice, 2016 and 2018. He is also a member of National Infection Control Guidelines Committee. Welcome, sir, to this session.
Thank you. Just give me a moment to share the screen. So, is my screen visible now?
Yes, sir, it's visible.
Thank you. So, good morning, all. So, we are starting the day with a bit complicated. Yeah, my slides are moving, right?
Slide show, if you could advance the screen.
Yeah, is it moving?
Sure, that was now you can continue.
I can't hear you well, but can you just confirm my slides are moving?
It's moving, it's visible, sir. Please go ahead.
Yeah, okay. So what I was initiating was that the PKPD topic a bit complicated to start the day. So however, the idea for today for me is that for the initial couple of minutes, I'll give you a very brief outlay of the theoretical part of it. And then we will come to 4 or 5 core principles which we apply in our day-to-day practice in management of infections. So that's the way the day is expected to progress. To start with, we realize that there are multiple factors that affect or impact the treatment of an infection. The antibiotic or pharmacokinetics or dynamics is not the only thing which matters when you treat an infection successfully. There are host-related factors. The immune response of the host plays an important part. That's not our topic for today anyway. We have pathogen-related factors, the resistance and the MICs of that, and based on cultures, which Dr. Sumit will be speaking about next. We have the antibiotic choices and selection part and how you use these drugs, and that's primarily my role today to discuss this third aspect of the dosing of antibiotics and how that would influence your antibiotic management. Okay, so to start with, all of us should understand this. This is just one among 3 aspects: the host response, how the pathogen and what kind of pathogenesis is, and then you have an antibiotic. And we are talking about just one part of this triangle, the antibiotic now. Now, when you talk about pharmacokinetics and dynamics, it's a spectrum. It's the 3 major components of pharmacokinetics are absorption of the drug, the distribution of the drug into various body compartments, and how the drug would be eliminated from our body, hepatic or liver or kidney or some other way. So it's basically 3 major aspects: absorption, distribution, and elimination, all of which primarily determines the drug concentration at the site of infection. So what happens in the pharmacokinetics in terms of absorption, distribution, and elimination is expected to culminate into the core aspect of what is called as drug concentration at the site of infection. And that's where the success of the therapy is determined, right? So that's how it reaches there. There are various factors that would affect the pharmacokinetics, and based on these, we often modify our doses. And that's what we are going to look at now. And what are these variable factors and why we should be aware of this variability and what should we do to address this variability. Moving forward, once you have the drug concentration at the site of infection, the next important thing for the drug is to have its efficacy, right, in terms of inhibiting the bacterial multiplications. So for this, we come to a value called as minimal inhibitory concentration, or MIC, which is on the graph what you see on the right on the dotted line. So what that primarily means is that the antibiotic which we give need to reach a certain concentration at the site of infection, which would be above the level which is required to inhibit the multiplication of that bug, okay, of that bacteria. So that's minimal inhibitory concentration, and we need to go beyond that. That's what the shaded region in this shows. So this will ensure that you have the effect of the antibiotic. So that's the last box in my slide, that is the drug effect. So you have the pharmacokinetics determined by absorption, distribution, and elimination. Based on this, you have the drug concentration at the site of infection, and based on the drug's concentration, you have the drug effect. So this is how the whole spectrum would follow. Now, based on the pharmacokinetic and dynamic aspect, we divide the antibiotics into 2 or 3 major categories. So why do we do this division is because to understand how to dose certain drugs in certain way. Okay. So one of the classifications from the pharmacokinetic perspective is dividing antibiotics into hydrophilic antibiotic and lipophilic antibiotic. Why is this important? This is because the volume of distribution of these drugs vary based on whether they are hydrophilic or lipophilic, and based on the volume of distribution, your dosing strategy changes. Okay, and I will explain how the dosing strategy changes. So examples of hydrophilic antibiotics are all your beta-lactams, your aminoglycosides like gentamicin, amikacin, etc., your glycopeptides like Vancomycin, Deco, your linezolid and colistin. So for these, usually it is predominantly renal clearance. They have a low intracellular penetration. However, when you use them in the ICU in the initial phase, especially in a sepsis patient in the starting 1 or 2 days of early sepsis, these are affected by increased volume of distribution. Okay. So being hydrophilic, while the patient is in sepsis, there is increased volume of distribution. These are affected by increased volume of distribution, and therefore their doses or dose requirement goes up in these situations. So it is important for us to understand this aspect, that hydrophilic antibiotics are more affected by volume of distribution in the ICU patients, and therefore their dosing needs to be on the higher end while we use them in the ICU. For the lipophilic antibiotics, even in the ICU setting, their volume of distribution is mostly unchanged, because to start with itself, they work at a high volume of distribution. So for your fluoroquinolones, macrolides, clindamycin, etc., tigecycline, and all these drugs, they are lipophilic. Even in an ICU setting, their volume of distribution is mostly unchanged. Hence, usually there is no requirement to dose them higher than what is recommended by the renal functions. Okay, so this is the first important aspect which we need to understand about the pharmacokinetics of antibiotics. The next aspect is about the site of infection. So we spoke that the impact or effect of antibiotic is based on the concentration at the site of infection, not necessarily the blood. So if the infection is in the blood, that's fine, but often it is in the lung, it is in the brain, it is in the soft tissue, etc., etc. So what matters in killing or inhibiting the multiplication of the bug is how much of this drug gets into the site of infection. Now, based on different site of infection, there is again differences in the pharmacokinetics. If it is only blood, especially in the sepsis scenario, you have enhanced renal clearance, and you need to figure in or add a component for expanded volume of distribution, and hence the requirement for what is called as a loading dose. Okay. So in primarily blood infections, which we assume when we have a sepsis septic shock, the requirement for a loading dose is present. This is because they have an expanded volume of distribution and also increased clearance. Lung also, especially ventilator associated pneumonia, etc., where the concentration in epithelial lung fluids is important, we tend to give beta-lactams and other antibiotics at a higher dose. Somebody has a soft tissue infection like skins and soft tissue, necrotizing fasciitis, cellulitis. Here, if the patient is obese, it would increase again their volume of distribution, and we need to increase the dose in an obese patient in this instant. Bone and CNS are two areas where the permeability or the ability of the antibiotic to get into that site itself is poor, and therefore these are the areas where we give higher doses with or without prolonged duration of treatment. Okay. So couple of key points to take back from this is that the site of infection often determines the dose. It determines the dose by impacting the penetration or ability to achieve concentration within the site. Sites like CNS and bone have poor permeability, hence they need increased dose. When we suspect a bloodstream infection, you require a loading dose because of expanded volume of distribution and faster clearance in the septic patients with bloodstream infection. Lung, it is recommended, especially in pneumonias, ventilator-associated pneumonias, to dose on the higher side. And in specifically soft tissue infections, when you handle obese patients, again, you need to dose at the higher side. With worsening sepsis, once your multi-organ dysfunction sets in, a whole lot of complications happens from the pharmacokinetic perspective. You have GI dysfunction, somebody is in shock, the blood perfusion is going to be to the other visceral organs, the body is going to take it out of the gastrointestinal tract, hence your GI dysfunction happens, decreased absorption of all enterally administration medication, so you can't give probably anything orally at that time. There is tissue hypoperfusion. If blood itself doesn't get well into the tissue, the antibiotic which you give IV also will get in less, hence it might result in underdosing. There could be hepatic dysfunction, where a couple of protein binding of highly bound drugs can come down. This will again reduce in underdosing, and it may reduce the metabolism of certain lipophilic drugs, and it would increase the levels of that, and it could result in overdosing. Similarly, renal dysfunction, it will reduce the elimination of hydrophilic drugs, and if you give normal doses, it might result in overdosing. So you see that with organ dysfunctions, the dosing becomes complicated. Often we need to and review it on a day-to-day basis to understand when to give higher dose, when to reduce the dose. So the rule of thumb mostly in these cases is that somebody with multi-organ failure and shock, we do not use enteric antibiotics anyway, that's a given. For the first 24 to sometimes up to 48 hours, we go with normal dosing of antibiotics irrespective of the renal dysfunction to adjust for augmented renal clearance. By day 2, day 3, we look at what renal replacement therapy is happening, whether it is intermittent dialysis, whether it is CRRT, whether it is low efficiency dialysis, etc. And then we adjust the dose based on the renal replacement therapy. So in multi-organ failure, what we need to remember is that for first 24 hours or so, give loading dose, give normal dose. Following that, reassess the organ functions, reassess the hypertension, reassess the renal replacement therapy, and then go for the adjustments accordingly. Otherwise, either way, you may end up either underdosing or you may end up overdosing. Now, slowly spilling over to pharmacodynamics, we already had a brief look at this graph where we saw that on the x-axis, you have the time after administration of antibiotic. So what you see on the x is the time after administration of antibiotic. On the x-axis, you have the concentration of antibiotics after administration. And what you see as the dotted line is what we called as the MICs, or minimal inhibitory concentration, at what we discussed, what the level needed to block or prevent the multiplication of bacteria at that level. So we know that our antibiotics need to be at higher than this MICs. So there are two ways of achieving this levels of antibiotic higher than MIC. You can aim for a peak or the maximum concentration of antibiotic above MIC, what is labeled there in green, the top as peak bar MIC. So you might give a large dose of antibiotics together that you get a very high concentration at a point of time and then it just goes down. Or you can aim for keeping the antibiotic at a higher level for a long time by giving multiple doses or by giving prolonged infusions. So that's called as time above MIC. So overall, when we look at the antibiotic effectiveness, we divide them into 2 or 3 groups. Okay, one classification we already looked at, that was the difference between lipophilic and hydrophilic. Now the next classification of antibiotics is based on their efficacy parameters. So what are these efficacy parameters? It can be 3. One, it can be based on the peak above MIC, meaning how much concentration the antibiotic achieves when you give the dose above the MIC. It's just the amount of antibiotic at one time. It is not about over time. It is the amount of antibiotic you reach at one time. 2, it might be time above MIC. So that is about how long the antibiotic remains above the MIC during the day or between the dosing interval. The third is what is called as area under curve. That is the full form of AUC, area under curve. So this looks at the overall antibiotic exposure. So it looks at the peak and it looks at the time and calculates the area. So it is overall antibiotic exposure. So you have three groups. You have antibiotic which act based on peak, antibiotic which act based on time, and antibiotic which act based on exposure. So what are they? The time-dependent antibiotics are penicillins, cephalosporins, carbapenems, macrolides, clindamycin, and linezolids, etc. The idea is to have maximum duration of exposure. And how do you achieve that maximum duration of exposure? By more frequent administration, like penicillins, you give 4th hourly, 6th hourly, or prolonged dosing infusions, like meropenem, you give after 2 hours, 3-hour infusion. Okay. So that's the basis of handling time-dependent antibiotic. Concentration dependent are aminoglycosides, fluoroquinolones, phosphometrozole, colistin, etc. Here you need to maximize the concentration, and here what we give is infrequent doses, looking at a single, the whole daily dose is given as a single shot so that it achieves the peak. We are not bothered about the time. Then you have concentration dependent antibiotics, predominantly which we are talking fluoroquinolones, etc., where the idea is to maximize the amount of drug exposure. And here we try to give the maximum dose possible within those 24 hours, either once or twice a day. This is example of levofloxacin or ciprofloxacin. Now, in the graph, it looks very simple, but in terms of clinical application and clinical impact, the MIC-based decisions are not that simple. It is not 1 + 1 = 2 kind of equation in real practice and in patients. So there are a lot of complexities in that. So one complexity is that when you talk about time above MIC or etc., it is often drug bug specific. So even for cephalosporins or beta-lactams, you see that for different bugs, for gram negatives, the time above MIC is different. For gram positives, the time above MIC is slightly different. For some, it is you need to have 95 to 100. For some, you need to have only 60 to 70. For some different kind of infections, for meningitis, you need to have more. For just a pneumonia or a skin soft tissue infection, you need to have less. So even though broadly, when we say time above MIC for beta-lactams, etc., we need to realize that how much time above MIC? Is it 50%? Is it 60%? Is it 100%? Depends upon the kind of infection, the kind of bacteria, and the kind of drug. This is a similar graph for also a slide also for aminoglycoside targets, that they have a small variation in depending upon the different bugs. Now putting all this together, the antibiotic class, that is it concentration dependent, time dependent, etc. The pharmacodynamic parameter, that is, do you want the peak or do you want the time or do you want the exposure? Then you have the clinical optimization strategy, right? So in practice, how do you implement this theory? So for concentration dependent, as we mentioned, we implement it by giving a high once daily dose. For time above MIC, we implement it by giving either multiple intermittent doses or continuous or prolonged infusions. Okay, so this is the clinical application of this theory of MICs and PKPDs, what we looked at. Remember that all these data or most of this data.
Yes, sir. Yeah, you can just switch off your video and continue the talk, sir.
Sure. Just a minute. Hello?
Sir, there's a problem with the transmission. If you can switch off the video, it will be better.
Yeah, sure. Is it better now?
Yes, sir. Definitely. Thank you.
Okay. Yeah, so what we are discussing is that all this, what we looked at, what we reviewed, is mostly based on in vitro and in vivo experimental models. Okay. And we know that there are a lot of limitations when you look at models. And hence, as I was discussing when we started, it is not often a one-to-one calculation. It's not that 1 + 1 = 2. Often what we see here, its translation into clinical practice becomes difficult because of this dynamics, what happens in clinical setting. Okay. However, going forward, we will look at 5 most commonly used applications of this PKPD. Okay, so we very quickly, the theory aspect we have seen, we know that antibiotics can be divided into lipophilic and hydrophilic, and based on that, the dosing varies. We know that antibiotic can be divided into concentration dependent, time above MIC dependent and AUC dependent, and based on that, again, our dosing varies. We know that antibiotics, the site of infection is important, and based on that, the dosing varies. Now we'll try to look at what are the clinical applications of all these. So how do you use this PKPD in clinical practice? There, I have picked up 5 major ones with maximum evidence. Though there are a lot of dosing strategies, I have picked up 5 aspects which has got maximum evidence in using PKPD in clinical practice. The first is looking at prolonged infusions for beta lactams. Now, this was published last year, and this is a review of all the systematic reviews. What it concluded was that in critically ill, okay, so where the time above MICs, volume of distributions, etc., are key factors in achieving clinical success, prolonged infusions of beta lactams have a favorable clinical outcomes. Okay. What you need to remember is that the systematic reviews have concluded this in a subset of population, only in the critically ill. Hence, this is not a recommendation for routine practice of prolonged infusions, primarily because in the wards and all, you have resource requirements in giving prolonged infusions. We may have issues with stability of the drugs in the room temperature in Indian setting. So putting this together, and the take back from the systematic reviews is that in the critical ill, in ICUs, probably it is a good idea for you that when you use beta lactams with piperazine, tazobactam, or meropenem, to go for prolonged infusions. The next most evidence-backed aspect is about aminoglycoside dosing. So for aminoglycoside dosing, the standard of care now is once daily dosing. The whole daily dose calculated as per body weight and renal clearance is given as a single dose. So what you see in the table is a summary of all studies which compared nephrotoxicity vis-a-vis single dose vis-a-vis multiple daily dose. You see that for all the scenarios, the single daily dosing of aminoglycoside had less renal toxicity compared to multiple daily dosing. This was extremely predominant in gentamicin and not so evident or not statistically significant for amikacin. So for basically amikacin, they could not show a major difference in renal toxicity with single or multiple dosing, but with gentamicin and netilmicin and others, they did. And hence, it is an opportunity for us to reduce nephrotoxicity and get better efficacy by giving a single daily dose of aminoglycoside. However, there is a caveat that this has not been evidently proven when we use aminoglycoside for synergy to cover gram-positive infections like staph prosthetic joint infections, endocarditis, or enterococcal endocarditis, etc. Here, still the multiple daily dosing is recommended. The third important clinical application is about higher dosing in septic patients. So this we discussed at length when we were looking at the volume of distribution and pharmacokinetics in sick patients. So we understand that in the early phase of sepsis, there is something called as augmented renal clearance irrespective of the creatinine value. And even when we look at certain renal replacement therapies like CRRT, or sometimes when the patient is on ECMO for lung support, the dosing of antibiotic requirement goes up significantly. So hence, do not dose the antibiotics in the ICU patients solely based on their creatinine value. Look at the mode of renal replacement therapy, any adjuvant support systems like ECMO, and also remember that in the early phase, because of augmented renal clearance, you need to give higher dose. So this is just a snapshot of what happens. So you have increased volume of distribution due to endothelial damage and capillary leak, and you have increased creatinine clearance due to increased cardiac output and use of vasopressors, and you have increased vascular permeability. So all of these results in the change in the physiology as what we discussed. The fourth practical point is that use therapeutic drug level monitoring for indicated drugs. So as I was mentioning when about the complexity of PKPDs, it is for few drugs where the therapeutic range is very low, narrow. It is very important for us to hit the sweet spot to definitely understand, to avoid underdosing and to avoid overdosing and toxicity. So there are certain drugs for which therapeutic drug level monitorings are available widely commercially, where there is significant evidence to show that they are of narrow therapeutic potential. Yeah. Hello. So the majority of these three drugs are vancomycin, gentamicin, and voriconazole. So at least for these three, we should have a system in place to look at therapeutic drug level monitoring and then use these drugs for regular practice. The fifth or the last take back is that we need to use high dose in certain conditions other than the ICU what we discussed. So high dose is used in meningitis, high dose is used in endocarditis, it is used in bone and joint infections and in those with high MIC infections. And about this MICs, I'm sure the next speaker, Dr. Sumit, would be discussing at length. So certain aspect where the concentration at the site of infection is low, we need to keep in mind about this high dose. So to summarize, the clinical utilization of some of this information is challenging because these are complex systems studied using in vitro and animal models, and some of them using what we call as population pharmacokinetics. A linear relationship between clinical outcomes and these parameters are difficult to establish, meaning if you do this, you will get better outcome. It's sometimes difficult to establish, but they lay down mostly the basic best practice principles. They help us in our dose and dosing strategies. So it is one way of optimizing the antimicrobial use to ensure that you have highest efficacy, you have least toxicity, and you have less chance of developing resistance. So 4 key take back points from this discussion. One is that we need to understand the PKPD category of the antibiotic, which requires prolonged infusion, which requires single dose infusion, which can be managed by short infusion, which requires multiple dosing, which is lipophilic, which is hydrophilic, etc. So that is the first part. The second is that we need to identify the clinical situation with altered pharmacokinetics, where the doses has to be adjusted. So this is septic shock, multi-organ dysfunction, patient on renal replacement therapy, etc. You need to acknowledge the site of infection and body weight because the dose will vary accordingly. So the dose will vary in obese patients. It can vary in meningitis and bone infections. Knowing the MICs might help in borderline cases where you can actually use a high dose of the regular antibiotic instead of an alternative antibiotics in select cases. And the next speaker will be speaking much more about the MICs. Thank you.
Hello. Yeah, thank you for the talk, sir. It was a totally different way of looking at things because as physicians, we do use the antibiotics in and out. But then you're looking at a totally different scenario like patient with sepsis or MODS. I mean, then we do need to consider the way and the dose at which we are giving these drugs. I have a question for you, sir. Now, when we are saying a patient who is in the ICU and who's on multiple drugs,
Hello, I lost you in between. Can you repeat the question, please? The patient in the ICU? Hello? Hello, I lost you in between. Can you repeat the question?
yeah, my question is that when a patient is on multiple drugs and we're looking at estimating antibiotic dose or looking at a different way of delivering the drugs in terms of duration gap. So what happens to drug interactions? How does it affect the antibiotic efficacy?
So primarily the drug to drug interactions are important because we know that there is a propensity for either adding toxicity, there is a propensity for either reducing or increasing the dose based on how that affects the metabolism. One of the common examples of these are when you have rifampicin on board for any reason. The other most common area in ICUs when you have azoles, antifungals, especially voriconazole, when you have voriconazole on board. So that is again something with high interaction. So for any situation where we have polypharmacy, definitely we need to look at drug interaction profile. It alters the drug levels in terms of either increase or decrease. That will have an impact on either efficacy or toxicity. We know there are a handful of antibiotic drugs which are known or notorious for drug interactions. So azoles, macrolide group, rifampicin group. So these three or four groups, whenever they are on, when we are macrolide, when you have quinolones, when you have azoles, definitely we should be on watch out for these drug interactions.
We will now proceed to our second session, Interpreting Cultures and Antibiograms, where